All right, guys, we're back where we picked up. So we were talking about clotting disorders, and now we're going to go to bleeding disorders. So remember, I talked about primary hemostasis, the platelet system, secondary hemostasis, the coagulation cascade. You're going to want to differentiate these with labs, but they're going to give you clinical hints. Primary hemostasis disorders present with petechiae and purpura, mucosal gum bleeding with brushing your teeth. Both can present with menorrhagia, but they're mostly going to present with kind of the superficial bleeding and bruising. Clotting disorders, you're going to see bleeding, especially after surgery, after trauma, and deep bleeding into organs or especially into joints. So hemarthrosis, you can get people with hemophilias often develop really bad arthropathies from recurrent bleeds into their joints. And getting a family history is really important to determine this genetic component of inherited disorders. So diving into the drugs. So I'm not going to read all of these, but key things. Aspirin, the mechanisms, irreversible, non-specific COX inhibitor. So platelets don't have nuclei. They can't resynthesize the enzymes. So aspirin works for about 12 days, and that's why you can take like just a small amount of aspirin 81, causes it to be platelet inhibitor. Larger doses actually get the anti-inflammatory effect. Plavix or clopidogrel irreversibly binds ADP receptors, preventing the expression of GP2B3A, as we talked about earlier. Prasugrel also similar mechanisms. Ticagrelor is a different type of drug. It's a non-thienopyridine, and it can have a faster recovery of platelets. Other things to note about Plavix: lots of people, there are some who either don't metabolize Plavix or don't respond. They were termed Plavix non-responders. So when you're on your cardiology rotations in your third year and fourth year, there are a certain percentage of people who have recurrent clotting on Plavix. So when you put a stent in and you keep them on their Plavix, and those people are non-responders, and you want to put them on something else. All right. Ticagrelor is also really expensive, so it's not as commonly used, but it can be better in some situations. So this is a little chart seeing how they work. Dipyramidol is not as commonly used. It acts by it's a phosphodiesterase inhibitor, increases cyclic AMP, which blocks the release of ADP. Clopidogrel blocks the ADP receptor to prevent platelet aggregation. There's also direct GP2B3A receptor blockers, mnemonic gate. So GP2B3A blockers are epiximab, tirofiban, and eptifibatide. Boy, those are a mouthful to say. Anyways, so this kind of just shows you that general, like where these works in this platelet activation scheme. Aspirin, of course, remember, blocks COX enzyme and decreases production of thromboxane. So the antithrombotics, so these are your coagulation inhibitors. So heparin acts via AT3. Remember, it has a risk of heparin-induced thrombocytopenia, which is caused by the formation of this binding with PF4, forming this kind of novel antigen, and the activity of these antibodies cause platelets to be destroyed. Good for renal failure, bad because it's repeat dosing and it's not oral. Lovenox has a lower chance of hit, has a longer half-life. You can give it once or twice a day. Usually it's given only sub-Q and not IV. It's often used for DVT prophylaxis in hospitals where you really see it because it's just a lot easier to dose than heparin. But you can't use it with a GFR below 30. So you have to watch for that. Fondaparinux, honestly, never seen that in the hospital, but it's an anti-10A. Warfarin, we talked about, mainly still used because it's so cheap and people have so much experience with it. So you're going to see it in people who have AFib with mechanical valves. the NOACs and DOACs, the direct inhibitors that you see down at the bottom of your screen, were proven to have increased risk of stroke compared to warfarin in people with mechanical valves. So that's kind of the population that warfarin has not been replaced in. Warfarin also has a lot of drug-drug interactions, requires you to follow their INR as an outpatient. A lot of things can affect it. So it's a tricky drug, but people, especially older practitioners, often use it. Direct thrombin inhibitors. So those are going to be things that you can use, especially if people have HIT. You can put them on bivalaridin or something like that as an alternative. And you can see this chart is just what factors are affected on the right here. Your NOACs and your novel oral anticoagulants, NOACs or DOACs, direct oral anticoagulants, rivaroxaban, apixaban, and dabigatran. They're great because they're oral, they're easy to dose, they work better, they work great for stroke prevention in AFib, and you can use them just like you would use warfarin, except for they're just a lot easier to dose and they don't require you to follow an INR. So great for outpatient stroke prevention. The one thing that people are worried about was, they're not really reversible. Warfarin, if you're giving it to people, you can give them vitamin K, give them factors back, and it easily is reversible. But the NOACs, you can't really do that. So if they come in with a GI bleed, like someone's on warfarin, they come in, their INR is 4, they have a GI bleed, you can give them that FFP right back, and they'll be okay. You can't really do that with the DOACs. But dabigatran now has this antibody that does allow for reversal. It's really expensive, and it still takes a little bit to actually replace it. So, but it is an option. Vitamin K and warfarin. Remember, warfarin's a vitamin K inhibitor. It's involved in the synthesis of factors 2, 7, 9, and 10, protein C and protein S. So remember, protein C and S are going to be your anticoagulant effects, and they're the ones that are first going to be affected when you give a vitamin K antagonist like warfarin. So that's why you have to do the heparin bridge, because protein C and protein S are the first ones to be affected. Then you will have a brief spell where you'll have increased risk of clotting. So you want to heparinize them during that time, and then eventually, once their INR bumps up enough, then you are fully anticoagulated and you can stop the heparin. So vitamin K deficiency, so increased risk of bleeding can happen at the antibiotic use. So if you kill your gut flora that make the vitamin K, newborns who don't have gut flora yet, it's why we give all babies IM vitamin K. Parents who skip this injection, and you will see this. I had a patient on the wards in 3rd year that did this, and there's a real risk that they'll get hemorrhagic disease newborn. They'll bleed into their brain and have serious consequences from that. Obviously, warfarin use and any sort of like malabsorption syndrome can also give you vitamin K. So think CF or something like that. Coagulation defects, so hemophilia. Hemophilia A is factor 8, B factor 9, pretty easy to remember. Hemarthrosis, easy bleeding, easy bruising. They are X-linked inherited, so you see them in boys, although sometimes you can get spontaneous mutations, so it may not be inherited. And there's varying levels of severity just depending on the amount of factor that's actually produced and how effective it is. You treat it by replacing the specific factor. There's actually a recent study that came out last week where they used an adenovirus vector to express the factor, I think it's for hemophilia B, but I'm not sure, in the liver. So infect hepatocytes with this vector for producing hemophilia, and they actually reduce bleeding by a significant amount. So in the future, we might not be replacing factors. We may be injecting people with these vectors, which is pretty cool. But for now, we just get factors. Von Willebrand's, so that's autosomal dominant, one of the most common inherited bleeding disorders. There's multiple types that you probably don't need to know too much about, but type 1 is the most common. They have a low absolute number, a quantitative deficiency of von Willebrand's, and usually have pretty mild symptoms. Type 3 is the most severe form. And they also have a quantitative deficiency, but it's very, very, they have much lower counts and much more severe symptoms. Acquired von Willebrand's can be seen in autoimmune diseases, so kind of all your rheumatologic disorders. Overall, it's, like I said, the most common. You want to diagnose this, take a really good family history, because remember, it's autosomal dominant, so you'll see it in a lot of family members. And you see decreased agglutination with the, sorry, I misspelled that, but ristocetin cofactor assay. So remember, that's the one that stimulates GP1B to bind to von Willebrand's. Normally should cause agglutination. If you don't see that, then there's a deficiency of von Willebrand's, or they have Bernard-Soulier. But most likely, it's von Willebrand's. And you can treat it with DDAVP, which causes von Willebrand release. All right, moving on to transfusion medicine. We'll just get an intro to this because we have a lot of it. But first of all, ABO blood types. Everyone has antibodies because they just are there at baseline due to kind of cross-reaction with bacteria. Usually they're mostly IgM, although there are some IgG. And they activate complement. So if you give someone the wrong type of blood because you made a mistake, then they have an acute hemolytic transfusion reaction with complement activation. But you guys obviously probably have known this table since high school, so we'll move on. The Rh antigen, so that is known as a dipeptide. Anti-Rh is predominantly IgG, as are the other minor antigens expressed on red cells. They can't officially activate complement, but they do cause extravascular hemolysis in newborns and cause hemolytic disease in patients who have had kind of a second pregnancy for Rh negative mothers. So that's why you want to prevent that initial immunization. So you want to prevent any fetal hemoglobin from getting to the mother. So if there's any bleeding during pregnancy, actually during delivery, even if they have if a woman is unfortunate and has a miscarriage, you want to give the Rh immune globulin. And what that does is it just binds up the fetal hemoglobin, or the fetal, the fetal red cells that get into the maternal circulation and covers those antigens so that the maternal antibodies can't see them. So you don't develop the anti-Rh antibody and therefore prevent hemolytic disease of the newborn in the first place. So basics of blood bank testing. So the type, so that's just the antigens on the surface of patient's red cell, so AB and Rh. The screen, so that's going to be testing for antibodies in patient's plasma. So that usually uses a standardized set of red cells. So red cells from just random groups of patients with all these different antigens that are known, and then you test for use the patient's plasma to test to see what antibodies are present, and therefore you kind of determine what their minor antigen compatibility is. Cross-match that's where you take the actual blood you're going to give to someone and see if it agglutinates with the patient's plasma. So it's kind of like the final line. It's really not done very often, but that is the it's kind of seeing in a vial if there's a reaction is actually going to happen and cause agglutination. And so we'll go in a bit to transfusion products.